the Algonquin, Anishinaabe, and the people of the Algonquin Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who also have made Ottawa their home. I also want to start with a statement. This is actually from the Heart Institute. I'm going to read this verbatim. This is from our board chair. So, but you can imagine that this could apply to any group of people, that while at the University of Ottawa Heart Institute, we can't get our arms around the world to comfort all those in distress, we are devoted to get our arms around our community to deliver world-class heart care, and in our own way, we can bring a bit of light into what can seem to be a dark time. So I think the nuclear medicine community you could substitute the Institute for CANM, and our nuclear imaging family would certainly, I believe, share those sentiments. So this is a special honor and tribute, and I want to thank Lionel Zucchier for this was his brainchild to think about having a cardiac session, and Nicola has been instrumental in implementing this. And the notion of this was to acknowledge and greatly appreciate this acknowledgement, the impact of the Ottawa Hospital and the University of Ottawa Heart Institute on nuclear imaging in Canada and internationally. But most in particular, to honor Dr. Terry Reddy, who is a great colleague and friend and a leader and mentor of many of us in the room. We will be honoring him more particularly this evening at the gala, but these two sessions are meant to honor him as well. And it's a tribute to that, to his collegiality and mentorship, that we've been able to attract strong international speakers from across Canada and around the world to be here today to speak at this session. So we'll begin the session with Dr. Prem Someone, who's going to give us an update on Cardiac SPECT.
Thank you, Rob, Dr. Beanlands. Good morning, ladies and gentlemen. I feel very privileged to speak at this session today. Every so often in our careers, we get an invitation or the opportunity to participate in something that's very poignant and memorable, that it stays with us forever. And for me, the opportunity to participate in a celebration of Dr. Ruddy's career is one such occasion. And I thank you, Terry, and the organizers for giving me this opportunity. Can I have the first slide, please? So my talk today is going to be about SPECT. I know the Ottawa Heart Institute and Dr. Ruddy and Dr. Beanlands and several others have had a profound influence on our understanding of PET and its utilization in cardiology, in addition to major contributions to SPECT. But today, still, 80% of nuclear cardiology is performed with SPECT. And so today, I want to acknowledge and celebrate some of the remarkable developments that have occurred in the field of nuclear cardiology with SPECT imaging. Can I move the slide? Oh, there you go. Thank you. Thank you. So as you all probably know, it all began with the publication of this paper and this rather fuzzy image, a planar image of myocardial perfusion imaging with radioactive potassium in the New England Journal of Medicine in 1973. And this is Dr. Barry Zaret, who, along with Dr. Bill Strauss, wrote that paper supervising one of the first stress tests with nuclear cardiology techniques ever done. And I would like, if you will forgive my boastfulness just a little bit, to point out to that autograph of the late Barry Zaret on this photo, and this is this is a very prized possession of mine. And from there, we went to planar imaging, much better quality planar imaging with thallium and then technetium agents, and then to SPECT imaging, initially with filtered back projection and then with iterative reconstruction. And today we have solid state digital SPECT with really exquisite image resolution. And you'll be surprised if I tell you that this is the image of a patient, non-attenuation corrected image of a patient who weighed 460 pounds. This is the qualitative imaging. So much so that if I ask you to pick up the PET image from among these three images, I'm sure you will point to the D-SPECT image because that has the most exquisite resolution. I can see that this is slightly unfair because I used a rubidium PET image, and you know, because of its positron range, the rubidium image is not the most resolved PET image. But just to make a point that image quality is exquisite. So today, modern SPECT is of course accurate, but in addition, it is efficient, it is patient-friendly, it is radiation sparing, and it is very versatile. These applications are beyond the scope of this talk, but today we can do flow quantification, we can do simultaneous dual isotope acquisition, which cannot be done with PET, and we can do desynchrony assessment. So it's a very versatile technique. The two commercially available cameras are the GE Discovery NM and the Spectrum Dynamics D-SPECT. And the solid state crystal, the CZT crystal, because it doesn't require any photomultiplier tubes, affords a small footprint and very patient-friendly imaging. The crystal has a very high energy resolution, and that's why we can do dual isotope, simultaneous dual isotope imaging, and there are some applications for this ability in clinical cardiology. The cameras have a very high sensitivity and resolution, but it's important to remember that these attributes are not a function of the CZT crystal, but rather of the proprietary collimator configurations and reconstruction algorithms. And the ability to acquire an image without the camera having to move around the patient allows fast imaging, dynamic imaging, and facilitates flow quantification. So because of this really high count sensitivity, the cameras are very efficient. With a standard anger camera stress dose of 30 millicuries of technetium, it takes about a minute to get 1 million counts in the left ventricle. Alternatively, we can use it as a dose sparing attribute. So we keep the imaging times relatively long, and we can go very low on the dose. Most of us do a bit of both. And so as this graph shows, with stress and rest imaging with a 515 millicurie dose, which is what we do, the radiation dose, the total effective dose is about 6.9 millisieverts, much lower than the recommended, the ASNC recommended dose of less than 9 millisieverts in about 50% of your studies. But with stress-only imaging, you can go even lower. And this important work from CEDAR shows that by going very low, you don't compromise our ability to do perfusion quantification. Quantification is still accurate if you go down to a dose as low as 1 millisievert, effective dose of 1 millisievert, and the quantification gives us the same results irrespective of the low dose. The high resolution allows much better separation of extracardiac activity. On the left side are a series of images: stress, line source attenuation correction, and rest on an anger SPECT. On the right side, the same patient with the same injection of tracer imaged stress supine, stress upright, and rest. And you can see here, there is much better separation of the inferior wall from the extracardiac activity, and this is a function of the resolution. Modern reconstruction algorithms allow us to use noise regularization approaches. On the left side is an unfiltered count profile showing the defect in the inferior wall. And our standard approach is to smooth that count profile. And you can see that how that produces a lack or a reduction in the contrast between the abnormal inferior wall and the rest of the myocardium. And by using noise regularization approaches, you can bring back that contrast between the abnormal and the normal myocardium and facilitate improved detection of myocardial ischemia. And here are examples of a ramp filter artifact because of the very high gut activity adjacent to the inferior wall with filtered back projection with ordered subset expectation maximization, iterative reconstruction, and OSCM with noise regularization. And you can see how the quality of the image is incrementally improved with these approaches. Now, I want to talk about 3 developments in SPECT that have significantly improved the accuracy and efficiency of the technique. And the first is fully automated quantitative interpretation. Here is a polar map with a large inferior defect. Using our standard visual semi-quantitative approach, we would apply a 17-segment model and score each of these segments using a scale. Now note that the perfusion defect does not respect these artificial 17-segment boundaries. So at the periphery of the defects, you have to decide if half the segment is normal and the other half abnormal, what number do you give it, right? So you get an approximation of the defect size. Fully automated interpretation, of course, uses a pixel by pixel assessment of the LV myocardium to determine which areas are beyond a 2.5 standard deviation threshold below a normal database. You get a much more accurate and precise interpretation of defect extent, which in this particular patient was 64% as opposed to a 70% estimate by visual semi-quantitative interpretation. And what is more, studies have shown that using this fully quantitative approach, the process actually outperformed expert readers at Cedars-Sinai based on AUC, based on the AUC for each approach. And then, of course, we have this very large observational data set of 19,000 patients with fully quantitative interpretation, still maintaining what we have seen in other observational data sets, that is a prognostic threshold of about 10 to 15%, beyond which revascularization produces a mortality benefit. Now, Dr. Ruddy was involved in these studies. We have not been able to reproduce this in randomized clinical trials such as ischemia, and why that difference exists is a topic for another day. But quantitative, fully automated quantitative approaches at least approximate the visual approaches that we are used to. The second approach, or the second development that I want to talk about, is artificial intelligence-based attenuation correction. Now, I think this is one of the most pragmatically useful applications of artificial intelligence. Now, as you all well know, one of the banes of nuclear cardiology with SPECT imaging is attenuation artifact. If there's one thing that impairs the sensitivity of SPECT perfusion imaging, it is attenuation artifact. Now, attenuation correction is not widely applied because it requires either a CT scan or line sources that need to be replaced periodically, and it incurs a cost. Now, with the virtual or sourceless AC, what is done is using deep learning algorithms, such as using a convolutional neural network, using paired polar maps of corrected and uncorrected images, the system is trained to predict the attenuation map from the uncorrected images. And on the right side is an example of this. On the top is a non-attenuation corrected image, which shows a large perfusion abnormality and a sum stress score, total perfusion defect of 19%. Now you see from the DLAC, or the deep learning attenuation correction, that the program calls it a normal perfusion scan. In fact, actually does better than CTAC. So you're going to turn around and ask me, what about this large perfusion defect? This happens to be a normal female patient. and the sourceless AC was able to correctly identify a breast attenuation artifact. There are a number of papers now showing us the efficacy of AI-based attenuation correction approaches. Here is one example from a commercially available program called TrueCore. It's available with DSPECT. You can see the top unattenuation corrected image has an inferior perfusion abnormality, and the deep learning based attenuation correction and the CT based attenuation correction both identified that inferior defect as a perfusion defect. And finally, you will be hearing more about myocardial flow quantification from Dr. Schwartz, but I wanted to show you one example of absolute myocardial blood flow quantification with SPECT using the DSPECT camera. On the bottom left is our setup there. There's no HIPAA violation. That's one of our technologies. And as I was reading this image, the first thing you see in the polar map is that there is an inferior perfusion defect that seems to be more pronounced on the rest image than the stress image. And my first inclination is this is an attenuation artifact. But as I looked at the study, there was an inferior wall motion abnormality. There was a regional functional defect in the inferior wall. Now, if you look carefully at the flow results, if you look just at the reserve, it appears that in all the territories and globally, the flow reserve is normal. But if you look more closely at the RCA territory, there's a profound reduction in the inferior wall in the rest study, but there is some vasodilation and some increase in the stress flow. So it turns out that this is a patient with hypertrophic cardiomyopathy who underwent a septal myectomy. And this was one of the early studies that we did and gave us a lot of confidence that the technique was giving us the physiology, at least in patients that we knew what the physiology was. The flow quant approach accurately reflected that. So how does this all come together in real life? So I want to show you one example of a 52-year-old woman who had prior bypass surgery, a large BMI, and presented with symptoms. And she had not an unusual constellation of clinical characteristics. She had chronic kidney disease, she had a pacemaker for sick sinus syndrome, and her ECG at presentation had atrial fibrillation and LVH. Now you see here that she had a number of characteristics that would have made alternative imaging modalities less preferable. CT, CMR, echo, the BMI, chronic kidney disease, pacemakers, AFib at rest. So in this particular patient, only SPECT is applicable. And this is a very underappreciated attribute of SPECT, and in fact of all radionuclide techniques, that you can apply it widely, irrespective of body habitus, contrast allergy, atrial fibrillation, the presence of cardiac devices, claustrophobia, inability of the patients to hold their breath, and whether patients can exercise or not. And in all of these situations, SPECT can be applied, whereas many of the other techniques cannot be applied. And this clinical effectiveness is a very, very important attribute of SPECT approaches. So if you look at the results in this patient, you have quantification of the rest perfusion defect, the stress perfusion defect, and the amount of ischemia. You have quantification of the ejection fraction, the total radiation dose, and this is what is reflected in our report. This is actually the report for this patient, was 6.9 millisieverts, below the 9 millisievert threshold, and you get a wealth of information. It tells you the patient's functional capacity. It tells you that we were able to reproduce the patient's symptoms on the treadmill. It tells you that there was ECG evidence of ischemia. It gives you a lot of confidence that the patient's symptoms were actually anginal, and then you have absolute quantification of the amount of ischemia of the left ventricle. So I will end where I started by saying that SPECT is accurate, it's efficient, it's patient-friendly, it's radiation-sparing, it's versatile. And what is more, last year we saw this image beamed across the world, an image that looks very much like a SPECT image, except that it was the first time our telescopes were able to see a black hole that looks very much like a SPECT scan. It made me think that this is further proof that all profound entities in the cosmos look the same. Thank you very much.
There you go. Awesome.